This conference will now be recorded.
Okay, so welcome to the class, and so we'll be discussing these three guidelines and associated questions, and I want to keep it totally interactive. So first we'll be doing this guideline Previa and Accurita, and then second will be Vasa Previa, and third will be this Abruption or Antepartum Hemorrhage guideline. Okay. So few slides for theory. I have not kept too much because that is not required. Now, what are the numbers? You know, in part 2 there are so many questions come from number. So this is a number slide for this guideline, Placenta Previa and Accurita. So I'll be sharing screenshot also, but this I have to speak. So incidence of Placenta Previa is 1 in 200. You have to remember this number. Prevalence of Placenta Ecorita is 1 in 300 to 1 in 2000. Okay, then chances of placental migration is 90%. And if any patient has got previous previous section, then this percentage will be less, but in the guideline they have never mentioned what is the percentage. Then at 32 weeks, 50% of the placenta still remain as previa only. Okay, so at 20 weeks, when it is diagnosed, so we are hopeful because in 90% of the cases it will migrate. So this number is important for you people. At 32 week scan, 50% of previa will still remain. Okay, this number is also important. You will get question. And this number, like if you are doing TAS, trans abdominal scan, and transvaginal scan, then reclassification of placenta occurs in 26 to 60%. From this number, I have seen a number of questions, so you have to remember this number. Then, if you are doing cesarean section for any other indication, and if you are doing it for placenta previa, so chances of bleeding is 12 times more. So you can get this 12 times as any question. Apart from this, if placenta previa is there and there is a bleeding, and if you put balloon tamponade, 75 to 88% reduction in the bleeding will be there. So these are the numbers that you may get question in the exam from this guideline. Okay, apart from this number is also important to remember, and this is a famous question also, like what will be the incidence of placenta previa after cesarean section? So this number, you know, you have to remember, there is no other way, and these questions, they keep on coming. So for one cesarean, after one cesarean, so actually they have given two studies. One, it was done in 1997. So the question usually comes from this. Okay, so if after 1 CS it is 4.4, after 2 CS it is 7. But you know, see here, after 3 cesarean, I don't know why they have said 6.5. So it is more in 2 cesarean, but it is less in 3. And for 4 or more cesarean, it is 44. So this number is easy to remember, 44 for more than 4. So these are the numbers that are given in the guideline from 1997 meta-analysis. But in this new guideline, they have added this also, that according to the 2014 studies, uh, if there had been one previous cesarean section, then chances of previa will be 10 in 1000, and if there had been 3 or more, then it will increase to 28 out of 1000 deliveries. Okay, so this newly has been added in this guideline. It was not there in previous guideline. So now there will be confusion what to mark. So according to the like numbers what they have given, you will be able to identify what actually they want in the answer. Okay, so these numbers are important from this guideline. So these are the numbers that I have collected for this guideline. Apart from this, everybody knows what is the symptom of placenta previa. I'm not speaking about that, but what I wanted to
Ma'am,
tell,
ma'am,
yes, yes,
there is one more data in VBAC guideline, ma'am. That is vaginal birth after cesarean. In that given, it is 1.7, 2 for 1, 2, 3 respectively, ma'am.
yeah, I know that, but
But
actually,
many times questions and answers from that only, ma'am. Like 1.7.
yeah, you are very right, but you are doing question books that carries question from 2015 guideline, but in the exam you will get question from this guideline. Okay, and if you are confused, always you have to put numbers or any answer from latest guideline. So this is the latest guideline in my opinion, so you have to remember this. Is it clear?
Sorry to
Okay,
interrupt,
ma'am.
ma'am.
Yes.
Sorry to interrupt, ma'am. This
Hmm.
is the relative risk, ma'am. Actually, in this guideline, the placenta previa guideline, they give as the relative risk, whereas in the way back guideline, they gave as the risk percentage.
Okay,
Even you wrote
so
that relative risk, RR. It is the
yeah,
RR.
this is RR, this is relative risk only. So
That
again,
is the risk. In the way back, it is given as the risk, ma'am.
I think in VBAC it is percentage.
Yeah, it is percentage.
Okay. So then now the problem is solved. If they ask you RR and they give you this kind of number, so you have to put answer from there. And if they give you percentage, you will be able to identify it in the exam because it is copy pasted question from the guideline. Okay. It is a confusing thing, but according to the question they have asked whether RR or percentage, you'll be able to answer because number will be familiar to you. Okay. Then symptoms of placenta previa, everybody knows this. I will not speak about that. I'm interested in this number. So if in cases of placenta previa, in 35% of the cases, baby will be in malposition, breech or transverse. Okay. This slide is from strategy. So this, like I'm telling you source. So 35% babies can be in a malposition. So only for this line I have put this slide. Now, okay, so this we can do from the guideline also. So usually like they have put that in an okay, I think we need to go, we should go for towards guideline because there it will come. Okay, so let's do I just want to keep it interactive. So in this guideline, like I'll be doing this from this point because in previous pages of guideline it is summary of recommendation, and summary of recommendation is you have to do it after you have done whole guideline. So we are doing it in a detail. So why we are not interested about summary. Now, okay, so I'll be asking question and you have to answer me. So Madhu, you wanted to volunteer. So you have to tell me.
Okay, ma'am. Yeah.
Yeah. So answer will be in front of you. So not an issue with that. So what are the risk factor for placenta previa? What do you think?
Usually the first and foremost risk factor is the previous cesarean deliveries, and another one is the advanced maternal age, and another one is the assisted reproductive technologies, and one is multiple pregnancies, and other one is the any any conditions that are recognized before the pregnancy, ma'am, like smoking, uh, yeah, and any
Okay.
other like uterine scars, endometriosis,
Okay, that will
manual removal. Yeah.
endometriosis will not come. Manual postpartum endometritis will come. So that will
Yeah.
that table will
Okay.
come again. In another guideline, that table will come again. So now we are interested in that. So we know this. It is cesarean section, increased maternal age, ART, and these are the few things where it can happen. Now, in placenta previa, we already know there was previous classification where grade 1, grade 2, grade 3 and 4 are there. Okay, but now they have changed classification. So now you have to tell me what they have changed it to low-lying placenta, placenta previa. Now you have to tell me what is low-lying placenta.
That is when the pregnancy is greater than the 16 weeks of gestation, the placenta, that is when it is less than 20 mm from the internal os, it is called the low lying.
Yes, and it can, so you have, this is very important. You will get question from this line. Why? Because you have to remember this 16 week. You have to remember like less than 2 centimeter from the internal os, that you will remember. And this is a real important. Here will be the confusing. Sometime they will say TS, or sometime they will say TVS. So you have to know. So it is for both for TS and TVS, and it is 16 weeks now. So this is the change in the definition. So this is the definition for low-lying placenta. If it is within 2 centimeter of internal os, and after 16 weeks of pregnancy, either on TS or TVS. Okay. So what is now this we have done? What is the incidence of placenta previa term? You will get question from this number.
1 in 200 pregnancies. Yeah.
Yes, that is very good. And for placenta Ecorita also, we had previous classification, but now they have put this word placenta Ecorita or placenta Ecorita spectrum. So it ranges from abnormally adherent placenta to deeply invasive placenta previa. Why I have highlighted, maybe they ask question from this line. Okay. Now, what is the different? What is the prevalence of placenta Accurita?
1 in 300 to 1 in 2000 pregnancies.
Yes, so you will get question from this number also. Okay, so this we have done, and Madhu already told that maternal smoking. So these are the risk factor for placenta previa in previous cesarean section. ART, maternal smoking. Okay, increased maternal age and multiparity is also there. So it will come somewhere. So now this number we have done. Okay, this I was saying that in 1997 study. So these are the numbers they have given, what I was showing, and they are telling the RO relative risk: 4 for 1, 7 for 2, 6 for 3, and 44 for 4. Okay, this we have already done. Like in 2014 meta-analysis, they have given this number. So with one section, it is 10 in 1000, and for with 3 or more, it is 28 in 1000. Okay, this part we have done. Now, ART is also associated with placenta previa and also advanced maternal age. So just need not to remember this RR number or OR number, but you can just compare that in ART it is like 3.7. For advanced maternal age it is 1.8. So if they give you sometimes they give comparison also in SBAs, like which is the most high, which have the higher incidence. So if they have given two things, so your answer will go to ART. Okay, so this is the definition for placenta, low-lying placenta again, that they have explained. So this part we have already done. Okay, so now at the anomaly scan, they have identified low-lying placenta. So as we already know that in 90% of the cases, we just read this number, there occurs migration. So we just want to take benefit of that. So TVS is recommended at 32 weeks to diagnose whether migration had happened or whether the placenta is still low-lying. So this is a very common question, and you already know this, everybody knows this. So if they give you a question when next you will call patient and why, so your answer will be TVS in 32 weeks, but it is, you know, everything before that. So now Madhu, you tell me, at 32 weeks you have called patient and you are doing scan. So how much percentage of the patient still will have placenta previa?
50% will have.
So at
50% will resolve and 50% they may have.
will stay back. Okay. So now 50% will stay back. So therefore, but what their study shows that even after 32 weeks, migration can happen. Because of that, they are doing one scan more at 36 weeks of pregnancy. Okay, it will come somewhere. Now, what do you, what do you think? TAS is good or TVS is good?
TVS is good.
Yes, and with the TVS, there is no further more complication. It is considered safe. Okay, now your patient at 32 weeks, she has placenta previa. So when you will call that patient again for scan, and what will be the mode of scan?
36 weeks
Yes.
with TVS.
Yes, with TVS. And if you get to know in this TVS, after 32 weeks, when you have done TVS, if you find short cervical length, so why you will be worried? What are the problems that can occur?
Yeah, there may be some preterm emergency delivery or any massive hemorrhage may occur.
Yes.
So has to plan the delivery.
Yes, very good. So this part we have already done. How much percentage of the placenta will be reclassified with the TVS? It will be 26 to 60%. This number we have done, and it is the commonly occurring question. Okay. Now, if the short cervical length is there, so there is a risk of massive hemorrhage, what we just read. So what is the risk? RR for that is 7.2. Just listen this one time only. I have never seen any question from this number. Okay. Okay, so your patient is like has a placenta previa and she's at home. So what the things you will tell to this patient when she has to come back, or will you admit? What you will do?
When it is the low risk, I'm sorry, ma'am. Can you please repeat the question, ma'am, please?
Yeah. So patient has at 32 weeks, patient has a placenta previa. Okay. Now, so you will give some advice. She will be in the home. Okay. Why to admit this patient? So, what advice you will give to that patient when she should see you?
Yeah, yeah. If there is any bleeding, like any contractions or spotting, or even some vague suprapubic period like ache also, they have to come to the hospital.
Yes. So this is one thing. And whenever we get a patient of like low risk, this placenta previa is there, we always do some safety risk assessment. And this is a safety risk assessment: distance between home and hospital, how far is the home from hospital, and what kind of transport facility is there. Okay. And whether we need to check her hemoglobin. So hematology laboratory results are important, and whether she's we have to rule out whether she is a Jehovah Witness or not. So these are the things that are our safety risk assessment. Okay, because if she is living far and no telephone or transportation facilities are there, maybe you will make some other arrangements. And if high risk patient, sometimes they may require admission also, but in UK that much issues with the transport is not there. Apart from this, if the hematology results are important, if any low hemoglobin, you have to just supplement with the iron. And also if they are Jehovah's Witness, that you have to really find out. If they are Jehovah's Witness, you have to make special kind of arrangement for their delivery. Okay.
Hey, hi, Dr. Priyata, ma'am.
Yes. Yes,
Ma'am, can
yes.
I ask a small question, ma'am?
Yes, yes.
Ma'am, if the
Yes.
patient present to us with bleeding, then should we do
Hmm.
a TVS or a TAS to rule out placenta previa?
Uh,
Because there's a
with,
question, ma'am. I think in Justin Knoje, the answer was given TAS. And some of the mentors explained that the patient is having bleeding, so we should do a TAS. That's why I'm asking, ma'am. Like,
if the patient is bleeding and it is a case of placenta previa, so
we
we
are
would
not
not.
sure.
No, then you can't do TV. Then you will. If the patient is bleeding, in my opinion, I will also take for abdominal scan.
Okay, the question was like that. If the patient comes to us bleeding, what should be done to rule out placenta previa? And the options were TAS or TVS.
And there was no bleeding.
There was bleeding. The patient present to us with bleeding, and the question was like, the patient came to us with bleeding, and to rule out placenta previa, what should be done? And the options were TAS or TVS.
Okay, so
Ma'am,
in
the
my
TVS is for the purpose of screening, ma'am, but to
yeah,
identify, diagnose.
yes, if the patient is
So if the
presenting
patient
with
comes in
bleeding,
bleeding, we need only the TAS, ma'am.
yes, in that situation, you will not poke that patient. You will arrange for TAS to identify it. But if you are just doing this management part of it, in that situation, you already know from the guideline it will be TVS. Active bleeding, you won't be doing
Okay.
TVS.
Okay, ma'am. Thank you
This
so
is
much, ma'am. Actually, ma'am, what in TVS, what we do is usually we don't go under cervix. We just keep our probe in fornix. So, anyways, we are not disturbing the placenta. That's why I thought the answer can be TVS. Because
yeah, but
clinically we are doing this, ma'am.
yes, but again, it will depend on the how much bleeding is there. Maybe if the patient has just spotting, we can do TVS. Okay. Otherwise, if active bleeding is there, I think answer it would should be a TAS. But again, see, guideline has never said anything about it. So what you have to do in that particular situation, what the guideline 2011 guideline that will be doing, that says that you should not do per vaginal examination until placenta previa is ruled out. Okay, so that specific things I never found, but if I
Okay.
had to answer, I will go for TS.
Okay. Thank you, ma'am. Thank you, ma'am. Thank you, Janetta.
Okay, welcome. So this part we have done. Like if the patient has asymptomatic low-lying placenta previa, so uh, we have to do some kind of counseling. What this patient is at risk at preterm delivery and bleeding. Okay, so that part we already know. So if these are again the safety precaution in place. So if placenta previa is confirmed at 32 weeks scan also, so we'll make it sure that some her home is near to hospital. Somebody is there in the house to take care of her so that she can reach to hospital. And we have to also do all inquiry about transportation and communication facility. And this part, we really do when we do station in part 3 for and patient has placenta previa. So we ask all these questions, so it is important for you people to know. Okay, and again, what do you think, is there any role of cervical cerclage?
No, ma'am. It is not supported. There is no
Yes.
supported evidence for that.
Yes, there is no supported evidence. Now, few things are there. So, though I have made a chart for that as well. So, if your patient has got no problem, okay, and she is at 32 weeks, diagnosed case of placenta previa. So, what will be your management plan?
At 34 weeks, we have to give the single course of antenatal corticosteroids. When because of the risk of the placenta previa, we have to give the single course of the antenatal corticosteroid because it is the uncomplicated between 36 and 37 weeks, she can undergo delivery.
Yes. So this number you have to remember, because they are very fond of giving a question from this, you know. So if patient is asymptomatic, you will give steroid between 34 to 36 weeks of pregnancy, and delivery will be 1 week after that. So it will be in 36 to 37 weeks. Okay, if patient has got no issues and no problem. I have made a separate slide for that also. Okay. Now what is the role of tocolysis?
Tocolysis is only for the administration of the antenatal corticosteroids.
Oh,
That is to
yes.
consider for the 48 hours to facilitate the administration of the antenatal corticosteroids only.
Yes, actually, whenever this
We cannot give to prolong the gestation, but only
yes,
for the action of the antenatal corticosteroids only we have to use the tocolytics.
yes, usually in whenever the bleeding patient is there, in that particular situation, actually tocolysis we are not is not should not be given, and even the guideline says that. But for some issues, you know, patient is stable and baby is also stable, and you just for the sake of corticosteroid, after expert guidance, tocolysis can be considered. Okay, so they will give you some kind of confusing scenario, but answer will come from there. So if they have given in the scenario patient is like patient is symptomatic but patient is stable and she is preterm, in that situation you will consider tocolysis. Okay, but if they give scenario where any maternal or fetal compromise is there, that you will get to know from their scenario, in that situation there will be no to tocolysis.
No tocolysis.
Ma'am, if the bleeding is ongoing, we need to give tocolysis. We need to deliver, no, ma'am.
Yes.
Yeah,
So
we cannot give.
The
At
bleeding
the time of
settled means
bleeding,
we
we
can give
cannot give.
tocolysis. We can prolong the pregnancy.
Yes. So if your patient is stable, baby is preterm, then for the sake of corticosteroid, tocolysis can be considered. But if any compromise, maternal or fetal, then you have to deliver this baby. You can't give tocolysis. Okay.
Ma'am, if the gestational age is just 28 weeks and there is ongoing bleeding, that time we need to deliver or we can prolong, ma'am.
No. If the bleeding is continuing, that means if you don't deliver, she will continue bleeding and you will lose baby or mother. Only
Mother
stable
is the
patient.
priority. Mother is the priority at that time.
Yes, mother is priority.
It is given in the guideline also.
Yeah, mother is priority everywhere on this earth. Not in
Ma'am, that
guideline.
time we need to consider steroids or we'll deliver, ma'am. Because
You
there
will
is one recall question is there, like that 28 weeks with ongoing bleeding. Their answer given like that, give steroids after 24 hours deliver.
okay. If you have to find out from the, see, I have said same thing. If you find your patient is stable, only the spotting is going on, parameters are fine, baby is doing well, you can consider giving steroid. Okay, but if any maternal and fetal compromise is there, like continued bleeding, heavy bleeding is there, or if baby's heart is doing something garbad, creating some problem, in that if any compromise is there for maternal or fetal side, in that situation you have to deliver that baby. Okay, there will be no role for tocolysis. So that you have to judge from the question whether you can wait for 48 hours or whether you cannot wait for 48 hours. So you have to analyze the situation. According to that, you have to put answer. Have I answered your question?
Yes, ma'am. Okay, ma'am. Thank you.
Okay. So this part we just said. that if there had been no problems, okay, patient has placenta previa, but patient is asymptomatic, then you will give steroid at 34 to 36 weeks, and you will deliver baby after 1 week, so or within a week, so it will be in between 36 to 37 weeks. So this the part will be done if there had been no ongoing bleeding is there. And why it is important, why they want to deliver at 37 weeks, they can continue pregnancy longer than that. This is because of this reason, because in placenta previa we always know there is a risk of emergency bleeding. So by 30, if the pregnancy is 35 weeks, so 4% patient will bleed. By 36 weeks, 15% patient will bleed. By 37 weeks, 30% patient will bleed. But it will become twice. 60% patient will bleed by 38 weeks. So to avoid this kind of bleeding, we are delivering asymptomatic placenta previa in between 36 to 37 weeks of pregnancy. This is just for understanding that I have never seen question from this number, so please don't remember this. Okay, so this
Ma'am, if this patient is diagnosed as placenta previa but she has no symptoms, that is asymptomatic, that time we need to deliver by 36 to 37 weeks. If she
yes,
has any prior bleeding episodes, we need to
yes,
consider delivery before 34, after immediately after 34 weeks, or that time also it is by 36 to 37 weeks.
no, I will tell you, just wait for that. I'll tell you. I will tell you that. Okay, just wait. So I have made a flow chart also, it will come. So that will make the things a bit easier for you people. So now this question, from this part, a number of question comes. Okay, so now I can put a question. So if Madhu, if a patient is at 36 weeks of pregnancy and she's diagnosed case of placenta previa, and you want to think that what should I do, whether should I allow this patient for cesarean section or whether vaginal birth can be considered. So what you will do?
At 36 weeks, we have to do the TVS, ma'am. TVS scan.
Yes,
At that,
yes.
we have to see the placental edge thickness, and also any echo is there, like a sponge-like echo or anything like a what is the thickness of the placental edge, and any marginal sinus is there. We have to see, and according to that, we have to plan the delivery.
Okay, very good. But this sponge like echo and marginal sinus, usually they never ask in the question, and it is very hard to see in placenta also. So what you have to remember, if your patient has got no problem, no symptom, and you wanted to take decision, so TVS can be done at 36 weeks, and you have to remember two words here. If it is
Yeah,
within
less than 20 mm. Yeah.
If the placental edge is within 2 centimeter of internal os, or thick placenta, okay, more than 10 mm, you have to remember this number, both number. Okay,
Okay.
if it is more than 10 mm, go ahead and do cesarean section. From this line, you know, you will ask so many questions, so you have to understand this. Okay, so please remember these two numbers, these are very important. Now what you will do if the patient
Doctor,
is yes,
doctor, can I ask a
yes,
question, please?
yeah, anyone can ask any question.
Okay, both signs should be present to consider cesarean section. يعني the lower edge less than 20 milli and the thickness of placental edge over 10 millimeter, or one of them only?
One of them only is enough.
Okay, thank you.
Okay. Yeah, this from here you will get question, you have to understand this well. Okay, so Madhu, if the what are the main complication we are worried about in placenta previa, what you will tell to your patient, what can happen?
Yeah, there may be massive hemorrhage might be there, So for the any indications for the blood transfusion might be there, and because of this massive hemorrhage, hysterectomy may be anticipated. So we have to see for that. And for the Jehovah Witness, any if they decline the blood or blood products, we have to see for that one. We have to document that what if they don't agree for the blood product, and any cells always we have to see for the cells always for them.
Okay, very good. So what we are worried about is blood transfusion and hysterectomy. And if the patient is not does not want any blood, in that situation we are worried. So we will send that patient to to the hospital where facility for cell saver and facility for interventional radiology is there, because in all hospital that facility is not there. Okay, so you are very right. And if they say what will be the immediate step, or they have brought to see advanced directive and documentation, so in some question you have to identify documentation and even advanced directive is sometime a answer. In UK usually there is a for Jehovah's Witness there is an advanced directive form. At antenatal visit, every woman who is coming for the antenatal care, so always they ask about blood transfusion, and if they are Jehovah's Witness, so they usually fill that advanced directive. It is done in the beginning of the in the antenatal visits only. They will not keep this patient for so long, and it is documented, and that advanced directive is signed also. Okay, so that is there. Apart from this, some of the patient they will accept some fraction of blood, or they may change their mind in emergency. All this part also we have to ask from the patient. But for you, that much knowledge is enough, because that more details are required in part 3. Okay, these patients being high risk patient, so you will deliver in a hospital where hematologist and blood bank is already there. This part we have done. We will always, if the placenta previa is there, we would like that their hemoglobin has to be built up. Okay, so this you can get as a question. Except Madhu, please everyone mute. Okay, so like this. So if the placenta previa is covering os, so if it is anterior, so these there are two independent risks for more bleeding. It is all placenta covering os and anterior presentation. So you may get question from anterior presentation or posterior presentation, but these two are the independent risk factor. Fine. Other risk factor that can cause increased bleeding. So what can be the other risk factor that can cause increased maternal hemorrhage, Madhu?
Yeah, pre-delivery anemia, thrombocytopenia, diabetes, and the magnesium use.
Okay, so these are the few things that you will get SPA from. So they will put some of these in the answer, your options, and you have to identify it. So now you can see even the diabetes. So this wasn't new for me, for my knowledge rest, I knew these are the factor for increased bleeding, but diabetes I never kept in my list. So diabetes is also there.
Even the magnesium use also is very new to me now.
No, magnesium, okay, I will tell you. Magnesium, usually it causes dilatation. I think it causes dilatation. It work on that NDMase receptor. So with the magnesium, this relaxation happens and chances of bleeding are high. With the magnesium, there is a problem. But you have to remember this, okay? Anemia thrombocytopenia, everybody knows. Just don't miss diabetes and magnesium. Yes, this you have to remember.
Okay.
So this I have already told. If you are doing cesarean section for any other indication, and if you are doing for placenta previa, how many times bleeding will be more?
12 times. 12
yes,
times
this part.
more.
Yes, this is newly added in this guideline. You may get question from this number also. Okay, so whenever they are doing cesarean section for placenta previa, it has to be, it will be a planned section. Usually it is done by the consultant, or consultant anesthetist should be there, or senior anesthetist. But sometime if the patient is coming in the emergency, then what you will do in that particular situation, you will if you are on a duty and you are starting cesarean, but it will be your duty, you will inform a senior obstetrician and senior anesthetist, so that will be important. Sometimes you will get only this in the question. So patient has come with this problem, you have a patient, she had a cardiovascular compromise was there, like BP was falling or something like that, you shifted. So what will be the next step, or what you will do? So in that situation, sometimes your answer will be called senior obstetrician and a senior anesthetist. Okay, this is important. And why it is important? Because after placenta previa, chances of PPH are more, and as we already read that in malpresentation is high rate, so complex maneuvers will be required. So we just remembered how many percentage of malpresentation is there in placenta previa, if anybody remembers. You remember it?
35%.
Yes, it is
35.
35%. Yeah, it is 35. Very good. Very good. Okay, now about the type of anesthesia. So regional anesthesia is considered okay, safe, but if there had been a compromise, like you have to take baby immediately out, expedition you have to do, in that situation, consideration for general anesthesia can be done, though it will depend upon the choice of anesthetist, and usually they never ask, from anesthesia part they never ask question. Okay, so whenever what should be there, whenever the cesarean is you are taking care, delivering, or you are doing a cesarean section, for that they should be, it should be in a tertiary, it should be in a hospital where blood bank transfusion laboratory is there. And it is also important, rapid infusion and fluid warming devices should always be there in their management. This is important. Cell salvage we have already done. This part is important, you may get question from there. uh, in post-operative period, if the hemoglobin is less than 70, like 7 gram%, so what you will do, whether you will like blood transfusion should be done or it should not be done? So what will be your
It
say?
has to be done. It has to be done. When it is
No,
less than 7, yeah.
no, it is not, it has to be done. It you will
Okay.
individualize the plan. If you think, okay, this patient will take iron, or you can give some infusion, but if you think no, patient has got a problem with anemia, she will not, she's not a compliant patient, so maybe you consider transfusion, but it is not must. It is like individualize, you have to individualize, it will be on patient to patient basis. And what type of blood given is, everyone knows it is O negative. um yeah, it is a O negative blood given, we know this. Now about the cesarean section, so you will get question from here, like baby is in a transverse lie, and she's 26 weeks of pregnancy, massive bleeding. What type of uterine incision you will give?
Vertical.
And yes,
If it is
so
below 28 weeks, vertical.
yes, it is, if it is less than 28 weeks, and if the baby is in transverse lie or in malpresentation, you would consider vertical skin and uterine incision. So you will go for classical section. So this is also very common question asked from this slide. Okay. And sometime if the facility is there in your hospital, or where the cesarean they do, usually they consider ultrasonography just before cesarean, So they mark the position of placenta. So accordingly they decide for what type of incision they will give. But sometime, you know, placenta has to be transected to take baby out. In that particular situation, there will be a very heavy there will be excessive bleeding if you have to cut placenta and take out the baby. In that situation, they apply umbilical cord clamp immediately, whatever they say in the Interpartum guideline, 1 to 5 minutes and all these things. So it will not be there in this particular situation if they are going through placenta. In that situation, immediate cord clamping will be done. Because why they are doing it? Because they want excessive blood loss, to avoid excessive blood loss. Okay. Then if the bleeding is there, because if lower uterine segment, it is placenta is in the lower uterine segment, so it is it is difficult to retract, so chances of PPH are more. So consideration for balloon tamponade, as sutures or interventional radiology can be done. But if the medical and surgical management are ineffective, it is early hysterectomy. Okay, before patient develops massive bleeding, organ failure and consumption coagulopathy, you have to take decision for hysterectomy. Okay, use at this part I have told. So
regarding that uterine incisions, the classical section only for less than 28 weeks, is it, ma'am?
yes, less than 28 weeks with male presentation.
And transfers, okay, ma'am. For other a term and all, we'll go for LSCS, ma'am. Lower segment.
Yeah, yes, for if it is more than 28 weeks, and if it is a cephalic presentation, you will go for like normal lower segment cesarean section.
Madam, when is the J-shaped, ma'am? J-shaped incision is also there in the guideline.
Yes, actually, if you think you have to, you're not able to. Usually, we do this in our clinical practice also. So, if you have started with the lower segment cesarean section, okay, so, assume a situation you are doing lower segment cesarean section, and you are not able to take out the baby. In that particular situation, you have to give incision on the upper uterine segment. So either you can give a small cut in the upper uterine segment in the middle. So either it could be inverted T, or you can give do the extension at the end of it, at the end of your lower segment cesarean section incision. So that will be J shape. Okay, but it is not a usual practice.
One more doubt, ma'am.
Yes.
If it is at less than 28 weeks, if they don't give the malpresentation, then can we choose the lower segment uterine cesarean, or we have to choose the classical?
Doctor, I think when we make a cesarean section for full term placenta previa, we go to make the incision in the upper border of the placenta, away from the upper border of the placenta.
Yes, you are.
No,
Yeah,
I'm asking for the 28 weeks, less than 28 weeks, when the presentation is not the transverse or any other malpresentation is not there, then which incision we have to choose?
Then in that situation, you know, you can go for a horizontal normal cesarean section, what you are doing. Somebody's mic is on. I don't know whose mic is on. Okay, so I'm repeating it again. If you get malpresentation, either it could be breech or transverse lie, and if you are getting less than 28 weeks gestation, your answer will go to a classical cesarean section. Okay, this is given in this guideline and also in preterm guideline. But on the other side, if they give you, if they are not mentioning any malpresentation, then though they have not mentioned anywhere in guideline, but then in that situation you have to consider for normal lower segment cesarean section, that what we are doing, because in that particular situation taking out baby will not be an issue. This is one thing. Second thing, if you are doing the cesarean section for term baby of placenta previa, in that particular situation what actually done, what is our worry, that we should be away from the placenta. So what they do, usually they do ultrasonography either preoperatively or intraoperatively also they do, because they have got a bedside machine all everywhere. So they just do the mapping of placenta. Okay, so they will put that mark on the abdomen. So here placenta is usually lying. So whenever they are giving incision, usually they want that they should give like abdominal incision or uterine incision, so placenta should not fall in their path. So because they don't want placenta to be transected. So for term baby they will do mapping with the USG before they put any kind of incision. Is the thing clear?
Yes, ma'am. Yes, ma'am. Thank you.
Okay, so now this part I have already done. If the patient has placenta previa and balloon tamponade is used, so it will be able to control bleeding in 75 to 88% of the cases. Okay, this part I have already explained. This part is also important. Now Madhu, you have to tell me, uh, you have put Becquerel balloon, okay, for tamponade for PPH in case of placenta previa. So what will be the factor that will cause failure of Becquerel balloon tamponade?
Failure of
Yeah.
the Becquerel balloon by the any anterior placentation is there, or
Mm-hmm.
any previous cesarean scar is there, or any thrombocytopenia or coagulopathy at the time of ingestion, it may fail.
Mm-hmm. And
And is pph volume more than 500 ml within first 1 hour of the placement.
okay, so you can get one SB from there. So what are the what are the condition where Becquerel balloon tamponade will not be of help? So it is previous section, anterior presentation, thrombocytopenia or coagulopathy. At the time whenever you have put the Becquerel balloon inside, and if there had been already more than half liter blood loss within first hour. Okay, so this line also you can get question. Okay, now a few things are, this is also important, though I have never seen a question. If interventional radiology is used, so what the follow-up study shows, this woman will have no further impairment of menstruation and fertility. Okay, so this line you sometime you will get in some stem of SBA. Okay, now this is all about placenta previa. Okay, now I have to where it is gone. Okay, so this is just in summary that you people have to. So this is the chart given in the guideline. Though I have taken this chart from the strategy, it is the same that is given towards the end of your guideline. What you have to remember is this. So because it appears to be complicated, with this slide you'll be able to understand, many of your questions will be solved only with this only, or with this slide. So if asymptomatic low lying placenta is there, now we are not worried. What we will do, we will do a scan at 36 weeks, and at 36 weeks we will look for placental edge. If it is more than 10 mm, or if it is within 20 mm of os, in that situation it will be cesarean section. Otherwise this patient can go for vaginal birth. Okay, so this is real important, you will get question from here. Now this is asymptomatic low lying placenta. Second situation, it is asymptomatic placenta previa. Now, so in asymptomatic placenta previa, we usually do scan at 36 weeks time, but we give steroid at 34 to 36 weeks, and we want to deliver baby 1 week after steroid, so it will be 36 to 37 weeks of pregnancy. So asymptomatic placenta previa, you have to remember this: steroid 34-36, delivery 36-37. Okay, 34-36 steroid, delivery 36-37. This you have to remember, because it appears to be real confusing, but they ask question from this part. Third scenario, placenta previa is symptomatic. That means patient is coming with off and on bleeding. So you are worried. So this patient can go in labor and you will end up in a trouble. So what you will do, you will think of delivering this patient early. So this is the condition. You have to give steroid before 34 weeks, and please deliver by 34-36 weeks. So it will not be difficult to remember if you go like this. And so this is summary: when you will deliver, when you will do steroid, and what will be the mode of delivery. But in your question, if it is coming Accurita, then according to new guideline, if any time you find Accurita, you have to send this patient for multidisciplinary management specialist center, and a delivery time is this: 35 to 36 plus 6 days. So this is the delivery time. So with this slide, you'll be able to handle all the questions where, by what time you have to deliver this baby in case of asymptomatic low-lying placenta, asymptomatic placenta previa, symptomatic placenta previa, and placenta Ecorita. What will be your management plan? Is it
Doctor,
clear?
okay, low-lying placenta means that the placenta in the lower segment only?
If a low-lying placenta will be within 2 centimeter of internal os. Placenta previa, it can cover os also. Okay.
Placenta previa is less than 2 centimeters from the os or covering, صح?
Placenta previa is covering os. Low-lying within 2 centimeter of os.
Okay. Okay.
Okay.
Thank you.
Yeah. Yes.
And placenta, in low-lying placenta, we can consider vaginal delivery. Is it, ma'am?
Yes, we have just discussed that. In low-lying placenta, at 36 weeks, you will arrange for scan. If placental age is like less than 10 mm, that means thin placenta. And if your placenta is more than 2 centimeter, patient can go for vaginal birth. Is it clear?
Okay, ma'am. Like one scenario in recalls, like placenta, low-lying placenta, and patient in labor and bleeding also. That time we can consider delivery, or we go for cesarean section, like that. Options.
So in that situation, if the possibility of scan is there, so please go for scan and find out from the scan if placenta, if your features are
But the
there.
patient is in active labor.
So they will give some additional knowledge about
Patient is
that.
in active labor, ma'am. Okay,
So
ma'am. But we can
yeah,
consider delivery.
In the
vaginal delivery.
guideline, it is
Okay.
given that when it is she's under the labor, in the active labor, we can consider the labor, vaginal delivery. It is given that in the guideline. One line is there.
okay. So they will give something more additional thing in the scenario also. So they will give some clue that you can this patient can go for delivery. Okay. Maybe they will give you some scan finding. Is it clear?
Okay, ma'am. Okay, yes, ma'am. Yes, ma'am. Clear.
Why? Because in the recalls, complete question never comes. So somebody remembers something, some part of question may be missing. So the confusion will not happen in the exam. You just go through guideline, you know, you will get answer what to put from the guideline only. Answers are completely from guideline. So this is very good about this exam, because you know the source from where question and answers are, from where you will get answer. Okay, is this slide is clear? Because you will get question from this slide only. Is it clear? Any question?
Yes, ma'am. Clear, ma'am. Yes, clear.
Okay. Now placenta Accurita spectrum. So this numbers you have to remember. So because and these are in percentages, and there is no other way, you have to remember it. So risk of placenta Accurita after 2 cesarean section it is 3%. Once after 1 it is 3%. After 2 cesarean section it is 11%. After 3 cesarean section it is 40. Then for 4 it is 60. Then for 5 it is 67. You will get question from these numbers. This is from the guideline, and same this is from the your strategy, and the numbers are same. You have to mug up these numbers. Now this is placenta Ecorita, when placenta is attaching directly to the myometrium, because that decidua basalis is not there. So in Creta, this is it will be in the myometrium. Per Creta, if it is coming to the serosa also. Okay. Usually this is the ultrasound MRI picture. I'm just showing this, but you will not get any MRI in the exam. So in the MRI, there will be abnormal uterine bulge can be there. There could be, you know, dark intraplacental bends. There could be heterogeneous signal density of placenta, problem with the vasculature, and disruption, like there will be no clear-cut placenta, uteroplacental zone will not be there. So I got this picture from strategy, so I put it here. But about the MRI, they never ask question. Okay, so now coming to, so that's all about placenta previa. So anyone has got any question to ask about placenta previa can ask. Otherwise, we are moving to placenta Ecorita spectrum. Okay, so what could be the risk factor for placenta Ecorita spectrum? So you everyone knows. So it will be like any kind of damage has happened to endometrium. So it could be cesarean, it could be any other uterine surgery, or repeated endometrial curettage. So because it will also cause a disruption or damage to the endometrium and myometrium, and the risk increases with the number of cesarean section. We just read that number. Fine. So
Previous history of Accurita also, ma'am.
yeah, that
Previous
will be
history of Accurita.
the previous history for placenta previa, previous history for placenta Ecorita. They will always be a risk factor. And you know, if any patient has a placenta Ecorita, they will be so horrified, they will never go for pregnancy again. This is a very bad experience for anyone. Okay, so what is the incidence of placenta Ecorita in placenta previa if the patient has no previous delivery? Okay, so this patient is getting maybe, you know, pregnant for the first time. She has placenta previa. So what do you think? What will be the incidence of placenta Ecorita?
3.3 to 4%.
Yes, so
With
you
the
can get,
placenta.
yes, so you can get question from this number. Okay, now this number I have already told, and you though they have given two kinds of number, two types of number here, but usually question comes from this percentages. question is not coming from OR. Question comes from percentages. This percentage everybody has to remember by heart, because you will get question. So you can remember it anyway. 3, 11, 40, 60, 67. Okay. For 1, 2, 3, 4, and 5 or more cesarean section. Fine. Now, what could be the risk factor for additional risk factor? Madhu?
Advanced maternal age, ma'am. And
Advanced
ART.
maternal ART. And if they give you a question, so maternal age is more than 35. Okay. So you have to remember this also. Now, this, if any, this you have to remember. If any curettage, we already know. Manual removal of placenta also we know. Please remember this. Myomectomy we already know, because it is again a surgery. But please remember this postpartum endometritis. So you will get questions. What are the risk factor for placenta Accurita? So I may do mistake. I will never consider postpartum endometritis in risk factor. So it is a risk factor. Please remember. Apart from this, if there had been no surgical history, so these are the factors again. So this also new in this guideline. So if anyone has a bicornuate uterus, if associated adenomyosis or submucous fibroids are there, and if myotonic dystrophy is there, so these are the risk factors where placenta Accurita can happen. So even this is new for me from this guideline. Somebody's mic is on. Okay. So this is again, you can get question from this number. So if placenta Accurita remains undiagnosed before delivery, in what percentage of cases? It is 1/2 to 2/3 of cases. So this is a quite big number. So if placenta Accurita spectrum, it will not be diagnosed in 1/2 to 2/3 of the cases. You may get question from this number also. Now, whenever there is a history of placenta previous cesarean section, and they find placenta anterior or low lying, they will always think of screening for placenta Accurita spectrum. Okay, so this is not a new thing we know. So what do you think, Madhu? What will be the finding that has got a best predictive value for diagnosis of placenta Accurita spectrum?
Abnormal vasculature. On the color
On
Doppler, abnormal vasculature.
Yes. So abnormal vasculature on CDI or color Doppler has got a best predictive value. No need to remember the specificity and sensitivity, because it's too much of a number. Okay, so what you will find on the ultrasound if placenta Accurita is there? So on a grayscale ultrasound, what you will find?
There's a Markleton appearance will be there.
Yes, and there will be increased vascularity. And sometime you will find big hole of lacuna, black color hole is there, and a big a large blood vessel is entering that lacuna. Okay, so these are the common finding that you may get in placenta Accurita spectrum. For your exam, you may find the question from this moth-eaten appearance. Okay. Now, in which cases, though the diagnosis is usually done from ultrasound scan,
Doctor,
yes. Yes.
So the diagnosis of placenta previa can be made easily by ultrasound, but the diagnosis of placenta Accurita by color Doppler. Yeah.
Yes, because you are looking for color, blood vascularity. You are worried about that.
It is used for diagnosis of placenta Accurita more than MRI.
Yes. Yes.
Okay, because this is there is a question about this. Okay, thank you.
Yeah. Now you can see it from here also. They have said it very clearly. Okay, abnormal vasculature on CDI has got a best predictive value. So if you do ultrasound yourselves, then you will be able to see you will see blood flowing like anything. I do ultrasound and I do Doppler also, so I know how vascularity looks. Okay, you will not be able to find that vascularity in MRI. I showed you a picture of MRI. This way MRI looks. Okay, from where you will find vascularity. Okay, now there are a few conditions you will consider MRI. So what are the conditions you will consider MRI?
Yeah, when there is a posterior placentation or when the ultrasound signs are there, like suggesting the parametrial invasion or any myometrial invasion, how much extension it is there. We have to know when we want to know the depth of invasion, then the MRI will complement the ultrasound.
Yes, very good. So now, though they are doing ultrasound color Doppler, it has got a best predictive value, but there could be confusion because if the placenta is lying on the posterior segment of the uterus, complete placenta in that situation will be difficult to find out their extent, so they can consider MRI. And if they have any suspicion that placenta has invaded to parametrium, or if any lateral extension is there, in that situation they have to find out before they open up this patient. So in this situation, consideration for MRI can be done. Okay, so this is important because this question comes from this part also.
Okay, doctor, I can understand that the MRI for grading of the placenta, I mean, it is placenta, only placenta accreta or invasion of the myometrium or reaching the serosa. Yeah?
Yes, because you have to plan your surgery that way. If you have got
Yes.
confused, you will consider MRI.
No. Yes, so MRI for grading of the placenta, for the placenta accreta, grading of the placenta accreta, yeah?
No, not for grading. It is like if on the ultrasound clear picture is not there, then you will consider MRI. If you are not able to find out clear, you don't know how much extent, like whether lateral invasion is there, whether blood vessels are there in the parametrium, whether they have invaded inside the myometrium. So you have got some confusion, your diagnosis is not clear. Okay, in that condition you will consider MRI. It is not routine. Now have I answered your question?
Yes, thank you.
Okay, so
ma'am,
usually
excuse me, ma'am, sorry to disturb. Ma'am, in the ultrasound you are mentioning, is it the transabdominal or the transvaginal we will be doing for the Accurita?
it will be TVS only. I think they have mentioned, yeah, TVS. Now you can see this line. TVS has an important role in early diagnosis, follow-up, and differential diagnosis. It is TVS.
Thank you.
Okay. Yeah. Usually, contrast can be put to increase sensitivity and specificity, but they inject IV gadolinum. But because of the pregnancy sake, safety data is not there, so they are not putting it. Maybe you get question from here. Now whenever so this you can get question from here, if you if patient of placenta accreta spectrum you have diagnosed, so you have to send this patient to a center where there is a facility for blood products, maternal ICU is there, baby ICU is there, and expertise are there for complex surgery, because this will be a very difficult case. Sometimes bladder may be involved, sometimes ureter may be involved, so the surgery is going to be very complex, so it has to be done in expertise center. Okay, then why we are worried and what can happen? So there is a risk of hemorrhage, uterine rupture, and premature delivery. This we already know, this can happen. Okay, now this part we have already done. So usually if they ask patient has placenta accreta spectrum, when she should be delivered, so your answer will be 35 to 37 weeks, or you just remember 35 to 36 plus 6 days. So this I have put in that slide, okay, because you will get question from this slide. But there are 20% of the cases where unscheduled emergency delivery will happen in case of Placenta Ecorita spectrum. You will find question from this number. Okay, so what could be the risk? What is the massive blood transfusion?
It is 8 units or more is the massive blood transfusion.
Yes, so you can get question from here. So these are the risks. It is DIC or coagulopathy, multi-system organ failure, death, and massive blood transfusion. So whenever this kind of issues are there, then usually consent is taken and the patient should be explained about all these things. MOH, massive obstetric hemorrhage, urinary tract damage, blood transfusion, and risk of hysterectomy. Okay, you have to remember this bundle. Okay, now 6 elements of this Placenta Previa bundle, because you will get question from here. So it will be consultant obstetrician and consultant anesthetic should be there. Blood and blood product should be there. It will be multidisciplinary involvement in preoperative planning. This is a preoperative planning. You are explaining patient about all this thing. Okay. Then you will discuss about the intervention, cell saver, and interventional radiology, leaving placenta in situ, and hysterectomy. So these you will explain this to the patient, and there should be availability of level 2 critical care bed. These are the 6 elements of the care bundle. You have to remember this because question come directly from here. Okay, so about the anesthesia, they are not asking question, but it can be done in general anesthesia, regional anesthesia. And but if anything goes wrong, consideration for general anesthesia can be done, or patient can be converted from regional to general anesthesia. So patient should know this before. Okay, now what will be the surgical approach? So they have given few things. So they have given 3 kind of thing. What could be the surgical approach in management for the Placenta Ecorita spectrum? So what do you what are the things they have explained, Madhu?
Yeah, one is the Caesarean section hysterectomy with the placenta left in situ. That is the preferable one. And the next one is when the entire placental implantation area is accessible and visualized, then partial myometrial resection can be done by preserving the uterus. And another is the using the preserving surgical techniques. Hello, am I told correct, ma'am?
Yes. So usually they do 3 kind of thing. So what is the best approach? Take out the
Best
baby.
approach is the Caesarean section. Yeah.
Yes. So take out the baby and please don't touch placenta, and take out the uterus. So this is the best approach because you are not handling placenta, so bleeding will not be there. Our aim is to avoid bleeding. So cesarean taking out baby, leaving placenta inside, and doing hysterectomy. Okay, this is the one approach and best approach. Second approach, if the patient say no, I want my uterus, so in that situation, what can be done? If you are able to delineate the placenta and it is not too much of invasion is there, then you can take out the placenta. Along with that part of myometrium can be taken out. So this is partial myometrial resection. Okay, this can be done. In that particular situation, you will be able to preserve this uterus. Okay, And if you are doing this kind of technique or partial bilateral resection, so the patient has to be counseled beforehand. So there has to be informed consent, and appropriate surgical expertise will be there. You know, a junior person doing cesarean section, of course, they will not do this kind of technique. Okay, so these are the few things that can be done. Apart from this, if the lateral extension is there, so it may involve ureter. So like consideration for ureteric stents can be done, but again it is not routine. Okay, there is enough data to support is not there. Fine. So these kind of thing can be done if you are dealing with placenta ecorita spectrum. So this they will not ask, because it was used to happen in previous OGRM article. This triple P procedure was there, but at least you have to remember what is triple P. In triple P, they three components are there. First P stands for peri-operative placental localization. That means going for USG or MRI. Second, pelvic devascularization. That means they used to do all this devascularization of the arteries, like ligation of all arteries. And third, placental non-separation. They will not separate placenta. So this is a triple P procedure. It was the approach they used to do previously, but now they're not doing all this triple P. Okay, because it was done in small cohort of the study only. So now what they are doing is this approach. Either they will take out baby and go for cesarean hysterectomy, one approach. Second approach, they will remove placenta if it is completely visualized and accessible. They will partial myocardial dissection. Okay, so now they either uterine preserving approach, or it is a hysterectomy approach. So they are doing this.
Ma'am, is there any role for leaving the placenta in situ, ma'am?
Yes, in Accurita. Okay, so this is these they have said in Placenta Ecorita spectrum, but Accurita, when it has come out of the serosa, so then there are four options they have given. So first will be same, primary hysterectomy after taking out. Second will be deliver the baby and leave the placenta. Okay, deliver the baby, leave the placenta. Third option, deliver the baby without disturbing placenta and go for partial myometrial resection or partial excision of uterine wall. Okay, if it is on small part of uterus, so they are removing partially that wall of uterus. For number 4 option, leave, take out the baby, leave placenta, and hysterectomy will be done after 3 to 7 days of cesarean section. So these are the 4 approaches. This Accurita. Is it clear?
Ma'am, please explain again, ma'am.
So if it is Accurita means they have placenta has involved serosa also. Okay, in that particular situation.
Ma'am, someone's mic is on, ma'am. It's very
Yeah, I know.
disturbing.
So there are 4 approaches. If Accurita is there, Accurita, okay. Either you first will be primary hysterectomy. That is always the best approach. Just deliver the baby, don't touch placenta, and do hysterectomy. Number 1. Number 2 approach, it could be take out the baby, leave the placenta. Then you have to put the patient on follow-up. Third approach, take out the baby, and without disturbing placenta, do not try to separate too much. Do partial excision of uterine wall. This is approach number 3. Approach number 4, leave the placenta and do hysterectomy, but wait for 7 days or 3 to 7 days. By that time, at least some of vascularity will reduce down. So that time doing hysterectomy will be a bit easy procedure. So they have described this 4 approaches for Accurita. Is it clear? Is it clear?
Yes, ma'am, clear.
Yeah. And
Yes, ma'am.
sometime, yeah, sometime they will find that bladder is involved. You may get this in a question also. If the bladder is involved, so what you will do? So if you try to pull out placenta, you will bladder will be injured so much. What they are doing, planned cystostomy, like they with the planning, they are cutting that bladder and they are removing the part of placenta. So with the planned cystostomy, like extensive damage to bladder muscle will not happen. Okay, it is important to know, because sometimes they may give you in some scenario bladder is involved, what will be the right approach? So you will give this answer, planned cystostomy is better because it will prevent less muscularis damage. Okay, so this may be the question that can come up. Okay, this is the so it was the funny thing, but again it is there. So you are doing cesarean section, Madhu, you are doing cesarean section, and you have opened abdomen, and you find, okay, now it is a placenta previa. Oh, sorry, it is a placenta ecorita, and your patient is fine. So what you will do?
Can we leave the placenta in situ that is given there? It should be considered.
Okay, I have asked question that I should not ask now. Okay, okay.
I'm sorry.
Yeah, that will come towards the end of it. So if the if we are leaving placenta in situ, then we have to follow this patient up. There would be increased chances of complication, bleeding, and infection. Methotrexate has no role. This you have to remember. Methotrexate is not
Ma'am,
given.
ma'am, I
Yes.
had one doubt. When the
Mhm.
placenta is leave in situ, how it will get healed and how it will get dissolved and everything, ma'am, without methotrexate?
Yeah, it happens. It happens. It happens. This happens by aseptic autolysis. Body take care of itself. Even in my residency, I have seen this case. My consultant, she left placenta inside. She followed her up, and after 3 months, scan was done, and placenta was totally, uterus was completely empty. It
Oh.
happens. I have seen.
Oh, okay. Thank you, ma'am. Thank you.
Yeah, and no methotrexate has got no role. Please remember this. Okay, so interventional radiology, it is not so sometime there is, you will get a question like prophylactic interventional radiology placement of balloon should be done, but what they are saying, it is not a routine, it is not a routine management. Okay, the patient should be advised, there could be possibility, but routinely it is not done.
Mainly for Jehovah Witness, ma'am.
Yes.
Mainly for
Yes.
those refusing that blood products.
Yes.
Interventional radiology.
But routine, yes, but routinely they are not doing it. Like if she's a Jehovah's Witness and you think bleeding will happen, so unnecessary you will not put balloon beforehand. So at say that time, like if she has problem, then only you will consider it. So it is not a routine procedure. Okay, so I was asking this question. So you are doing cesarean section, and you find you after opening abdomen, you find that you are dealing with placenta ecorita spectrum. So what you will do?
We have to close the maternal abdomen and urgent transfer to the specialist unit for the delivery
Yes,
to other place
yes,
where everything is available. We have to transfer the patient.
yes. So this question I was asking before, and this is a
I'm
new for
sorry.
me as well. Yeah,
Yeah.
no, sorry. So this is a new thing for me as well. So they will open the abdomen if they accidentally find acreta. So if the facilities are not there, so they will close it and they will send it patient urgently to the specialist unit for delivery. But you are
Ma'am,
stuck. Hmm. Yes.
ma'am, there were two questions regarding this. The one question was that you are performing a emergency cesarean section and you found placenta accreta. What should we do? We should call the consultant, or we should proceed, we should inform and proceed. The another one was that we are doing a elective cesarean section
Hmm.
and you suspected placenta accreta. You have seen placenta accreta in drop, then what should we do?
Okay.
For elective, we can delay.
So if in
Ma'am,
For
your
emergency, we need to go with the emergency hysterectomy.
yes, you are right, Juneta. But in emergency, they ask that you should proceed with transverse incision rather than classical. It's given in Justin Kanoji. That's why I was thinking, why transverse? Why we cannot do classical? That was my doubt,
Classical
basically.
only in the classical
but why
only
you
when
will
it
do
is less
classical?
than 28 weeks. No?
If she's a term patient, why you will do classical section?
Yeah, term patients we
Ma'am,
cannot do the classical section.
ma'am,
Hmm.
but there was lower vascularity. So we should avoid cutting placenta. That's what I was thinking.
Okay, if they have given something like that in the question, like lower segment placenta in the lower segment.
Vascular. Yes, ma'am. I'll post both the questions, ma'am, in your group.
Okay.
In case of placenta previa only, we consider that uterine incisions. In Accurita, there is no place for incisions.
Yeah.
No, in both the
In
questions
Accurita,
there was increased vascularity only.
okay, you can send that question so we can discuss that. Not an issue. I
Yes,
have
ma'am.
done this just book in the group, and that question I remember. We had a discussion, but now exact thing I don't remember that. But we had discussion about this question also.
Okay, ma'am. Thank
Okay,
you,
but
ma'am.
yeah. So
Thank
if
you.
the placenta accreta, if you are dealing with suddenly you get to know that you are dealing with placenta accreta, and in your hospital facilities are not there, then you can close the abdomen and send this patient to a specialist unit for delivery. But if now you are stuck with it, then please take out this baby, leave placenta in situ, and you do emergency hysterectomy. Okay. So this is take home for us as a gynecologist also. Hope no one should get in this trouble in their life. But if ever any of us in a trouble with this situation, so we have to take out baby and we have to do elective hysterectomy. Okay. Now, clinical governance issue, patient should have a postnatal debrief about implication in future pregnancy and fertility. Training issues, you have to be aware what are the risk factors for placenta ecorita. Whenever such thing happens, usually clinical incident reporting is done. So that's all about this guideline. Any question?
Hello.
Yes.
Ma'am, in the for the diagnosis of placenta ecorita as compared to three-dimensional sonography, the color Doppler is more sensitive?
Yes, we just
Okay.
read it has got a best predictive value.
Okay. Thank you.
Yeah. Just for general knowledge, I can tell you where 3D ultrasound useful. Okay, because I do a lot of ultrasound, so I have I can tell you. So if you have got like you are dealing with congenital anomalous uterus, any septum is there, any some mucous polyp is there, any fibroid is there. In those cases, 3D ultrasound will give you very good picture. You will be able to find out how much big fibroid is there, whether it can be done hysteroscopically, or whether it have in the polyp that stalk is there. These kind of things are very well you'll be able to find from the three-dimensional scan. Okay, but when you are worried about vascularity in any situation on this earth, okay, from top to bottom in human body, you have to put color, and color is color Doppler. Okay, you will remember this thing forever now. Is it clear?
Thank you, ma'am. Thank you.
Yeah. So now the guideline number 2 is Vasa Previa. Vasa Previa, only few questions come, you can do that in 5 to 10 minutes only. So you have to remember the incidence. So incidence is 1 in 1200 to 1 in 5000. This number you have to remember. No other option you have. Then um, uh, even if you are able to diagnose it and you are going to manage it, there is a possible fetal mortality is 60%. Therefore, we are afraid of this. These number you have to remember. Then most of the time, they will be able to find out in the second trimester scan. And you will get question from these types of Vasa Previa also, type 1 and type 2. So type 1 plus Vasa Previa, where these blood vessels, okay, these are the blood vessels. They are attached to the membranous part of the placenta. So this is filamentous cord insertion. This is the most common picture. It happens in 90% of the cases. So this is placenta previa, sorry, Vasa previa type 1. Now go to this. So there could be another kind of situation where placenta has got two lobes. So this is one lobe, this is another smaller lobe or succenturiate lobe. So there will be vascular communication. It is unsupported by Watson jelly or placental tissue. This type of Vasa previa is called type 2, and it is less common. It occurs in 10% of the cases. So this much information you have to, it is important to know because you will get questions. Now this whole thing I will send in the group screenshot. So prevalence of Vasa previa is 1 in 1200 to 1 in 5000. We know this. Fetal mortality rate is 60%. I have seen question from this number as well. Total blood volume at term in a baby, it is 80 to 100 mils per kilogram. I have seen question from this. You have to remember this number. Now if you are able to diagnose Vasa previa at 20 weeks, then self-correction occurs in 20% of the cases. You have to remember this number also. And if your diagnosis is confirmed, so this is the only one condition, where they want prophylactic plus hospitalization. So you will get question from this also. So you have to admit this patient as 30 to 32 weeks of pregnancy, and usually it is a call for planned section, and planned section you have to do at 34 to 36 weeks of pregnancy. Every number of this slide is important. Usually you will get question from this as only. Okay. Now coming to Vasa Previa guideline. So we will again start from this part of guideline, because summary of recommendation we are not doing. It is the same what we already know. So usually it is these vessels, they are protected by Watson jelly or placental tissue. If they are unprotected, these are Vasa Previa. What is type 1 and what is type 2? Now I have already shown you with the picture, so I'm not speaking. And fetal mortality rate is 60%, and this is incidence is this. So this I have already explained to you. So they will give you scenario. So what they will say, there had been a rupture of membrane, all of a sudden fetal heart falls to 90, or they will give that pathological CTG type of picture. Then your diagnosis will be Vasa Previa, and your answer will be immediate, like category 1 cesarean section, and along with a neonatal resuscitation. Okay, now there will be second situation. This is newly added in this guideline, it was not there before. So if baby, because of what you made diagnosis of Vasa Previa, you did everything to save this baby, but baby died, so you have to send this placenta for pathological examination. This is new part of this guideline. Then you can get question from this line also. So painless bleeding in case of Vasa Previa. So this is the name they have given. So this is bank casier hemorrhage, they are saying. So this is new word for me as well, but you may get question, what is this bank casier hemorrhage? This number I have already told. Total fetal blood volume at term is 80 to 100 mils per kg per kilogram of body weight. This number I have seen questions. Now at the time of anomaly scan, whenever they are doing, if they are able to diagnose Vasa Previa at that time, so it is good, because at that time false positive rate are very less. Though again, because these are vessels, so whenever you are dealing with vascularity, please think of Doppler. So combination of TAS and TVS color CDI or color Doppler imaging is the best diagnostic accuracy for Vasa Previa. Please remember this. If they write like transvaginal Doppler with CDI, if they get option with transabdominal with CDI, and third option is both TVS and TS with CDI, then your answer will go to this. Okay, combination of TAS, TVS provides best diagnostic accuracy for Vasa Previa. Okay, this is the definition of Vasa Previa, because you will get question from this also. So it has been defined as vessel running in the free placental membranes within 2 centimeter of cervix. Okay, so this definition is important. So usually if the diagnosis is done in anomaly scan, then you have to reconfirm it, because in 20% of the cases spontaneous resolution happens. Okay, you will get question from this also. So what are the if you find patient has got 1 or 2 risk factor, then during anomaly scan you have to look for Vasa Previa. So these are the risk factor for Vasa Previa. So you can read, tell me what are the risk factor for Vasa Previa.
That the placenta previa, bilobed placenta, succenturiate placental lobes, conception by the ART techniques, and velamentous cord incision.
Okay, very good. So these are the risk factor for Vasa Previa. So if you think that there are 2 lobes of placenta, please look for vessels. If you find out any succenturiate lobe, please look for vessels, ART, and also velamentous cord insertion. Though in my life, I have never seen all these situations. Okay, this number I have already told you that it resolves in 20% of the cases before delivery. Okay, so now prophylactic hospital will be done at 30 to 32 weeks of pregnancy. You have to remember that. Delivery will be with a cesarean section, and delivery will be at 34 to 36 weeks of pregnancy. Only this much is important in this guideline. From this, only whatever I have said, question come from this part only. Okay. Okay, steroid we always give. So steroids are recommended from 32 weeks. As they are delivering baby at 34 to 36 weeks, usually we give steroid minimum 1 week before we want to deliver the baby. So you just remember, you would require, this patient would get admitted at 30 to 32 weeks. You have admitted this patient at 32 weeks. Please give her steroid at 32 weeks. Now, your steroid will take some time to act. Please go for elective section at 34 to 36 weeks. All numbers are important when you will admit, when you will give steroid, and when you will deliver this patient. Okay, these type of question comes from Vasa Previa. So that's all about Vasa Previa. Any question? Any question? Okay, somebody wanted this slide, so you can see this slide again. Okay, so now we are moving to guideline number 3, and this is also real important guideline. So these are the number from that this guideline, Antepartum Hemorrhage guideline. So these are the number to remember. APH complicates 3 to 5% of pregnancy. Preterm that happened due to APH is 1 in 5. This is very common question. Everybody knows this number also. Abruption after one CS is 4.4%. After 2 cesarean section, abruption is 19 to 25%. USG failed to detect, 3 to 4, 3 out of 4. That means 75% cases of abruption, USG will not be able to detect. Therefore, we say whenever the patient is coming with bleeding, we arrange for ultrasound to rule out placenta previa, but we are not able to diagnose abruption. This happens in the clinical scenario also. Okay, you people have seen, I have.
Ma'am,
Yes.
ma'am, this is abruption after 1 CS. No, this is with previous one abruption is 4.4. Previous 2 abruption it's 19.25. It's not CS, I guess, in the guideline.
Okay, so I have done. Okay, I will recheck. Yeah, I think you are right.
After 1 abruption, what is the recurrence rate? It's 4.4, and after 2 2 incidents of abruption, what is the recurrence rate? It's 925.
Yes, you are right. This is a recurrence rate. So yeah, when I was making slide, it was always cesarean section was in my head. So if 1 abruption is there, so chances of recurrence was 4.4. If 2-time abruption happens, chances of again 3rd-time abruption will be 19 to 25%. These number you will get a lot of questions. Okay, you have to remember. And thank you, Ankita, for correction. And USG will be able to will not be able to diagnose 75% cases of abruption. So in case of bleeding, we just do ultrasound. Why? Because we have to rule out low placenta previa. And if patient is admitted with abruption, CTG will be abnormal in 70% of the cases. Okay, so CTG will be abnormal in the guideline. They have written 69, so you can remember just 70% of the cases. So these are the few numbers you have to remember from this guideline. Now placenta, we already know what is placenta abruption. And one thing you have to know, previously when our UG days we used to do the definition, we used to say bleeding from the genital tract from 28 weeks of pregnancy, but now they are taking it as low as 20 weeks of pregnancy also. This is from strategy. this is, why what problem really happens in placenta, placental abruption. Usually there are two mechanisms. Just a bit of theory. There occurs inflammation and there is a vascular dysfunction. Now, what happens when the bleeding occurs? It occurs it begins in the decidua basalis. So it causes separation of placenta from uterine wall, and then this blood enters inside the uterus also into the myometrium. So therefore, this cavalier uterus happens, and because of this, like contractility of the uterus is hampered. So and also there is increase in the intrauterine pressure during contraction because of the collection of bleeding. So all these problem with the abruption and also PPH happens. This is a theoretical thing. Nobody is going to ask question in MRCOG about it. Now these are the clinical features. Everyone knows what will be the clinical feature for abruption. What I in most common symptom will be bleeding. It occurs in 70 to 80% of the patient. Okay, and also uterine tenderness will be there in 70%. So just this is the most common symptom. So you bleeding and tenderness. Rest, all other thing we already know. Okay, fetal distress can be there in 65%, and death can be there, fetal death, in 15%. All these numbers are from strategy, but I have never seen a question from this slide. But still you can just remember this 70 bleeding and tenderness and fetal distress. Though we know CTG is abnormal in 70, so distress will be what this strategy says 65%. Death number you can remember, it will be in 15% of the cases. Okay. Now these are the grades of placental abruption. I just put this slide, but they have never asked any question. So there will be question will come, but before that we have to do another guideline. Okay, now any other person want to do this guideline, because Madhu will be is speaking for a long time. Anyone, any other volunteer? Otherwise Madhu will continue.
Okay, ma'am, I will do.
Okay, good. So Madhu, you can rest. Okay, so
Thank you, ma'am. Thanks a lot.
okay, welcome. So Madhu, you were right. Usually bleeding from genital tract. Previously in my UG days, what I learned is bleeding from 28 weeks. Guideline says it 24 weeks. So this number is important to remember. But strategy says consider as low as 20 weeks. So if the question comes in your exam, so you have to put this 24 weeks, okay? Because guideline knowledge is the best. GTG is the #1 for answer. Okay.
Ma'am, actually, no, in India, we remember 28 weeks because we take in India the viability age is 28.
Yes.
But in UK, the viability age is 24. That's why they take it 24 and we take it 28.
Yes. So therefore it is problem for us people, because whenever we are doing this exam, we have to do this exam from the UK knowledge only. We cannot put Indian knowledge.
Yes, yes, ma'am.
Okay, so yes, so for your question, you have to say APH is from 28 weeks. Okay, so this number I have told. So how much pregnancy it will be complicated? 3 to 5%. And how many babies will be preterm? It will be 1/5 or 1/5. You will get question from all three numbers. Now this is very important. So what will be okay? So tell me the classification for spotting. What will be spotting? What will be minor and major hemorrhage? Major question come from this
Spotting
part,
means it's
and
just
yeah, spotting means just a
staining or noted underwear, just
Yes.
spotting.
Yeah, it's just a spotting. So you will later on find in this guideline. So if the patient is coming with the spotting only, so in that situation, patient can go back home. No need for admission. And these 3M, you have to remember, because very confusing. So what is minor, major, and massive? No other way you have to remember. So what is minor hemorrhage?
Minor is blood loss less than 50 ml, and that has settled already. Major
Yes.
is
And what
50
is
to 1000 ml with no signs of clinical shock. Massive is more than 1000 ml and or signs of clinical shock.
Yes, these definitions you have to remember, because you will get question directly from here. Okay, so this part we have just done. Like after one abruption, it is 4.4. After two, it is 19.19 to 25%. So what are the risk factor for placental abruption?
Preeclampsia, fetal growth restriction, non-vertex presentations, polyhydramnias, advanced maternal age, multiparity, and BMI, low BMI, pregnancy after ART techniques, intrauterine infections, PROM, and any abdominal trauma, either it is accidental or from domestic violence, smoking, and drugs like cocaine and amphetamines during pregnancy.
So everything you remember, because they ask questions from this part, but please remember this BMI. So some all the things whenever we read, they are with the women of high BMI, but this abruption will complicate low BMI patients. Okay, because mistake will be done at this point. Okay, so what do you think? What are the thrombophilias that are associated with placental abruption?
Heterozygous factor V Leiden and heterozygous prothrombin 2210A.
Yes, so these are two factors that can be associated with abruption, but you will find later on. But what they are saying, that giving heparin to this patient will not prevent abruption. Okay, these are the risk factor for placenta previa, what we were doing before. So every of this thing, like nothing is new. So it will be previous placenta previa. So I think somewhere I have seen this question with the OR also. So it is OR 9.7. At least for previous placenta previa, remember this OR. Okay, so it will be like any damage has happened. So it will be cesarean, it will be termination of pregnancy, multiparity, advanced age, multiple pregnancy, smoking, and deficient endometrium, ART. Okay, so how many cases of abruption occurs in low risk pregnancy?
In 70%, ma'am.
Okay, and this smoking or tobacco, cocaine, and amphetamine, these are modifiable risk factors. Okay, because you can encourage women not to take it. This part I've already explained. There is no data that antithrombotic therapy will help in prevention of abruption. Okay, so whenever what they are saying, it is a good practice even not to have vaginal, they are avoiding. So we know that intercourse should not happen, and vaginal examination should not happen in the patient of placenta previa. But this is a new thing, because I read this guideline so many times, but I miss always this. They are saying avoid vaginal examination, also rectal examination, because with the rectal examination also they can poke placenta and bleeding can happen. About the intercourse we already know. Okay, so these are the complication of APH. So you can go get question from here, but just remember that this RTA, renal tubular necrosis, occurs. Rest complication you will be able to remember. Okay, just remember these two things: RTA, consumption coagulopathy, and postpartum hemorrhage. And because of the contractility of the uterus is hampered, therefore this PPH occurs. Okay. Now this we already know. So whenever a patient is having bleeding and she is pregnant, you will send or transfer her to the hospital where facility for resuscitation, anesthetic support, blood transfusion, emergency cesarean section is there. This is common thing, you know. Now the patient is coming in that triage. Okay, so in that particular situation, what you will do, you will see the cardiovascular status of the woman or mother. Like if the blood pressure, pulse falling, patient is in a shock, or any issues with the fetal heart, then in that situation, you know, you have to just do the emergency management, whatever intervention you have to do according to the situation. So they will give you a scenario. If you find a maternal or fetal compromise, you have to deliver this patient. Okay, mother is always a priority. Someone was saying it is in the guideline, but it is always everywhere on this earth. Mother is always first. Now if the compromise is not there, you know what will be the next step? You have to take full history. So if the patient with bleeding in pregnancy coming and there is no compromise, so what history you will take?
History of whether the pain is there associated with the bleeding. If it is painless bleeding, it will go with the placenta previa. No?
Yes, painless is placenta previa.
Because we have, in case of pain, we need to rule out labor also.
Yes.
Labor, it is intermittent pain, whereas in abruption, it is continuous.
Yeah, because of the increased bleeding inside the uterus, uterine tension is increasing, so there will be woody hard uterus and continuous pain. Yes.
And any other risk factors for abruption we need to identify.
Yeah, we have just read that.
And fetal heart to be monitored, ma'am.
Yes.
To be identified. Sorry,
yes.
identified.
Yes.
Then any spontaneous or iatrogenic rupture of membranes.
Yes, because if you find that yeah, blood pressure is like fetal heart is dropping, so you will think placenta Vasa previa, and you have to take smear history. Okay.
Sometimes it may be due to that cervical cancer.
Yes. So for part 2, this is not too much important, this paragraph, but it is important for part 3 because you have to take history from the patient. So these are the points you will cover with the role player. Okay, so it will be if it is a tense woody heart, you are dealing with abruption, and if it is like soft uterus and painless bleeding, you are dealing with previa. And if it is bleeding and there is a drop in the heart, you are dealing with Vasa previa. So sometimes they give you EMQs, you have to diagnose. So these are the clue to diagnose, though you know this is easy things.
Ma'am, drop in fetal heart can be in abruption, no, ma'am?
Abruption, you know, it will not suddenly fall down to 60, 70. Abruption, it will show changes, but it not be such sudden.
Okay,
CTG changes, yeah, CTG changes will be there. Like you can get suspicious CTG, or you can pathological CTG, suspicious CTG in abruption. But in Vasa previa, you will find that acute prolonged bradycardia of 3 minutes. Okay, so picture will be different in both of the things.
Okay, ma'am.
Okay, so this we already know that we do a scan to diagnose placenta previa. We are not able to diagnose abruption because in 75% of the cases, it is scan will not show anything. Now you will get question from here. Okay. Now if the patient is having massive hemorrhage, so what blood test you will arrange?
Blood count, full blood count, and coagulation screening, ma'am. And we need to cross match blood for 4 units.
And
urea, electrolytes, and liver function test should be tested, ma'am.
Yes, so they ask this question in the exam. For massive or major hemorrhage, what blood test has to be done? So you have to answer everything. It is FBC, coagulation screen, 4-unit cross match, urea, electrolyte, and liver function test. So this is the complete answer. Now, if the only minor hemorrhage is there, okay, so we just read the definition of minor hemorrhage. So what type of blood test you will do?
That time we'll do full blood count and grouping and just a cross match.
No cross match here.
Coagulation.
Only
group.
Only 2 tests you will do. It is FBC and group and safe. So this part is important because many people will make mistake only this simple thing. So for minor hemorrhage, it is FBC and group and safe. Only 2 tests. Okay. Don't make mistake here. This part I have already told that ultrasonography will not be able to diagnose 3 coater or 70%. Yeah. So about the fetal monitoring, like either you will do CTG, but if you are not able to find fetal heart on CTG, so what you will do? You will arrange for?
Ultrasound.
Yes, you will arrange for ultrasonography. Then this part I have already explained. Fetal heart rate will be abnormal in 69% of the cases. Okay. You may get question from this number. Now, if the patient has spotting and she is not bleeding, she has come to hospital. So what you will do?
We can assess and we can discharge, ma'am.
Yes. So you will say after clinical assessment and if it is reassuring clinical assessment.
Reassurance, we can send them home.
Yes. And if any bleeding more than spotting, that is whether it is minor, major or massive hemorrhage, you have to admit this patient. You will get question from these 2 lines. Okay. Only spotting patient that is settled, you can send back home. All other patient you with the bleeding, major, massive and minor, you have to admit them in the hospital. Okay. Steroid things we already know, so I'm not speaking it again. Then again, this tocolysis part we have discussed previously also. Usually tocolysis is in abruption, it is not given, but if mother is unstable or if baby has got any kind of compromise, but if the baby is very preterm, you have to transfer, and in that particular situation for very short time tocolytics can be given, and that will be after advice from a senior obstetrician, because tocolytics will further increase abruption. Fine. So this is important to understand because they usually ask question from this part. Is that clear?
Yes, ma'am.
Okay, and now nifedipine is associated with maternal hypotension. Though nifedipine is the first line tocolytic, but in cases of abruption, it should be avoided. Okay. Then you will get question from here.
Atosiban.
Yeah. Second line is atosiban. Yeah. Second line is atosiban. Now you will get question from this line. If there is a bleeding in the pregnancies from cervical region, and this patient was a low risk patient, so she will go back to midwifery care. Okay, you sometime you will get question from this referral also. But if the patient has abruption, unexplained bleeding or anything, and previously this patient was showing to midwife, now her care will change. So she will be in the consultant, she will be booked in a consultant led unit. And also there will be serial growth because bleeding had happened, so we're worried about IUGR. So now this patient will be a case for the serial ultrasound scan. This is not a new thing, but you usually get question about this booking, or whether this patient should be sent back to the midwifery care. Okay, now this part is important. I have seen question from here. So if a patient is at unexplained APH, so which is the highest risk? Okay, so so which is the highest risk if the patient is at APH?
Oligohydramnios.
Yes,
Oligo
this is
is the highest one.
yes, because I myself did this question wrong because I thought IUGR should be in the number one reason point, but no, it is oligohydramnios. So please remember this. So number one is oligohydramnios, then it is a PROM, IUGR is number 3. Okay, so
Growth
please remember.
restriction.
Yeah, it will be number 3. Everybody knows about growth restriction. So
Ma'am, fetal growth restriction is second one, ma'am. 5.6.
yes.
And PROM is 3.4.
Yes. Yes.
PROM is the last one.
Yeah. So just remember this oligo followed by IUGR. This will answer your question. Oligo followed by IUGR. Okay, so from here also you will get question. Now patient with bleeding has come. So if a baby, if fetal death is there, okay, baby is already died. Now whether this patient will go for cesarean section or for vaginal birth, that you have to find out. For example, if the patient is in grade 3 placenta previa, or in that situation, whether if the IUD is also there, then also you have to go for cesarean section. If transverse lie and IUD, you have to go for cesarean section. You will find question from this part. And if fetal compromise is there, like CTG showing changes, please do cesarean section and save this baby. Don't forget the resuscitation of mother simultaneously. So if they give scenario where fetal CTG changes are there and they give options, so just look for the option where they have given two choices, cesarean section and concurrent or resuscitation of mother. Okay, so if maternal compromise or fetal compromise, please deliver this woman immediately. But if no compromise, then whether you will go for C-section or whether for vaginal birth, that will depend upon the PA and PV finding. This few lines are important to understand because you will find certain scenario and answer will come from this part. So is the thing clear?
Ma'am, in strategy it is given if I diagnose that placental abruption, and when the fetal heart is there, we should deliver immediately, ma'am, because chances of fetal death is high with abruption. We should not give place to fetal death.
Yeah, you are right. But in that situation, you have to, reassess. If already dilatation is 7 centimeter, she is in pain, you will deliver vaginally. But if she is bleeding, the case of abruption, and like cervix is not favorable, you have to go for cesarean section. So, this changes.
Okay.
Now, if the patient is there with the bleeding, but her bleeding is settled, so ideally you want to deliver at 37 weeks of pregnancy. Okay, so you will put the patient on conservative management to avoid preterm delivery. But if you find in your scenario patient with bleeding after 37 weeks, in that particular situation, if you get any question, you have to do induction of labor with a vaginal delivery, and in order to avoid any kind of like compromise to happen, because why to keep this baby after 37 weeks? So if the patient with bleeding either with is coming in the obstetric emergency, so deliver that patient. Okay, and if the bleeding is settled and she is less than 37 weeks, there is still chance for this thing is there, like conservative management is there. Okay, you may get question from here also, like if the patient is in labor with the bleeding, about the monitoring you can get question. It is if there is a very small bleeding was there, and right now patient is settled, so mode of like baby monitoring will be intermittent auscultation. But if either on the ultrasound there were features of IUGR, or if any issues of continuous bleeding is there, in that situation you have to consider for CTG, continuous fetal monitoring, you have to arrange. About anesthesia also it is the same thing. Regional anesthetic can be recommended, but if there had been any compromise of maternal and fetal condition, then consideration for maternal resuscitation and expedition of delivery has to be done. Okay, so from this line you will get this question. So what type of if the patient had abruption, so what type of drug you will use for management for third stage of labor? So this is the answer.
Symptomatic.
Yes, symptomatic. Yes, you have to remember this because they give question from this part. Now, if the patient is having recurrent bleeding, patient is RH negative. So what they want, you have to give NTD. So how much, at what interval it has to be given?
6 weekly intervals, ma'am.
Yes, this is also a very common question. Okay, so after that, you like they have there is a, so whenever there is a flow chart is there at the back of the guideline that will do, so that will cover all this thing. So if the any massive or major hemorrhage is there, so delivery has to be attended by senior pediatrician or neonatologist. But if continuing hemorrhage is there, so like you have to request for pediatric support, because usually this baby will be anemic, or there will be fetal compromise will be there. So ideally this delivery has to be attended by the pediatrician. It is not a very big thing, Okay, so this is the postnatal thing, though it is not very important. But whenever this any thing happens, postnatal debrief to mother is real important. So she should get, usually they call them after 6 weeks time for postnatal follow-up. That time debriefing has to be done, clinical incident reporting has to be done, and assessment for thromboprophylaxis has to be done. Okay, the question usually comes from this part of guideline. Okay, so this is the, like if the patient is coming, they will give one scenario, and then they will ask about management. Okay, so answer will come from this pathway. This is important to remember. So it is A, B, C, D, E. E is like environment. So A is for airway, B is for breathing. Everybody knows it. There is no issue. So and C is for circulation. D, you have to decide, assess the baby and decide the mode of delivery. So now, sometime they will ask you what will be the next step. So first of all, you have to look for A. A is airway. If patient has got airway open, that means you have to go to next step. So next step will be breathing. Breathing, it is usually we have to look, it is look, listen and feel what if they have described in the collapse guideline. New guideline has come, you have to do for 10 seconds. So if your patient is breathing, so you can ask someone to put oxygen. then someone will look for circulation. And if the patient has got airway and breathing, then you have to take care of circulation. And usually they ask question from this point also, how much sample you will take and what the test you will send. So you will take 20 ml of sample, and for FBC and coagulation screen, urea electrolyte, and a cross match has to be done. And if the woman is RH negative, consideration for test for FMH or fetal maternal hemorrhage has to be done. So now, if in your examination, if they have given patient has an airway patent, then your next level of like what will be the next step? You have to assess for airway and breathing. But if they have given, okay, patient is breathing, the respiratory rate is this, that means your A and B are okay. You have to go towards C. C will be your circulation. So this way you have to put your answer of emergency in ABCD pathway. So then you will be able to find, when they ask you to give next, what will be the next line of management, your life will be easy. This you have to remember by heart. So you will find question from here. So patient has got no sign of shock, no shock. So what will be the next you will do? Here it is IV cannula, only one. So you will put only one cannula and you will start crystalloid. Usually it will be either Hartmann or RL. So this is their very favorite question. There will be another kind of question where patient has clinical shock. So you have to learn this from top to bottom in the same sequence. Why? Because they will give you airway, breathing is okay, so your answer will be evaluation for circulation. Sometimes like they have managed patient till IV access, so what will be your next step? So from this portion only will be answer. So you have to remember this. First A, assess airway. Second B, assess breathing. Third C, assess circulation. Now after that you will ask someone for oxygen. If your C is there, that means circulation is there, please put IV access. And now it is 2. Okay, you will get a question from this also. Here it is 1 and here it is 2 IV access. Pregnant patient has to be in recovery or left lateral position, and you will start actually you have to give blood to this patient. But if the blood is not available, you can start giving her crystalloids up to 3.5 liter, out of which 2 liter can be Hartmann solution, that can further followed by colloids. And usually what they say, rapid fluid warmer should be there, because they to avoid any kind of hypothermia. But special kind of blood filter should not be used. Why? Because they will slow down the infusion. Now you will get question from this also. So you can give crystalloid up to 2 liters, colloid after that 1 to 2 liter. Total it can be 3.5 liters. Okay. And fresh frozen plasma, actually this fresh frozen plasma and cryo precipitate, they are given depending upon the like coagulation profile. But if coagulation profile is not there, then you have to do something. And if you are waiting for the result, you can give 4 unit of FFP and 10 unit of cryo, or 2 packs of cryo. Okay, empirically, while you are waiting for the result. So this you will get question from every part of this. Then if you have given 4 unit of fresh frozen plasma, you have to give, if for every 6 unit of red blood cells. So it is this is the ratio, 4 units of FFP to 6 unit of red blood cell. This also you have to remember. Now sometime you will get when you have to give platelets, if it is less than 50. When you will give cryo, if it is fibrinogen is less than 1 gram. Okay, so this you have to remember, because in PPS guideline also same thing has come. So you have to remember that. But in PPS guideline, they are giving 4 unit of FFP to 4 unit of R blood cells. So this Yeah, this is a change in PPH guideline.
Ma'am, but
This,
fibrinogen level also changes there, no ma'am. Here
yeah,
it
2
is
grams.
to attain target level of 1 gram, whereas there it is 2 gram. I think.
Yes, it is 2 grams. So now this number you have to remember, because you will find the question from there. So what will be your target? You want hemoglobin more than 8, platelet more than 75, and a fibrinogen more than 1. So everything you find more than. Only PT and APTT you find less than 1.5. Okay. Though sometime confusion may happen, just remember only one thing you find less in number, that is PT and APTT, that will be less than 1.5 from the mean control. So this part of the guideline you have to learn. There is no other way. Be very careful whether they're asking for like bleeding with no clinical shock, whether they're asking bleeding with a clinical shock. Sometime in your station answer will be start a protocol for massive hemorrhage. So you need not to explain all this. You have to take only food protocol for massive MOH or massive obstetric hemorrhage. So only this will be the answer. So they are very fond of this kind of answers. So that's all for it. Yes.
Ma'am, if blood loss is up to 5,000 ml, there is no need to blood transfusion, ma'am? Or it depends on the patient?
Basically, it will depend on the clinical circumstance. There could be no hard and fast rule.
Okay, ma'am.
Okay, so now you can do questions. So one by one you can answer. So whenever you wish. So this is a question. Read this. These are the options. Sorry, this is the question and these are the options. So you choose. What will be the answer?
C, ma'am. Refer to unit with cell salvage or interventional radiology. Because she's a patient of Jehovah Witness, she refuses blood transfusion.
Yes, so answer is C, refer to unit with cell salvage and interventional radiology. So this is the question.
Options, ma'am.
Options.
Ultrasound, ma'am. Transvaginal.
Yes, it is TVS. So this is the question and this is the answer.
Imaging at 32 weeks, ma'am. 20 weeks scan.
Yes, it is
The problem is
TVS. Okay, ma'am. The gestational age at 32 weeks only, na, ma'am.
Yeah, because these are the questions, from previous guideline. But
Okay.
yes, it has to be TVS. It has to be TVS at 32 weeks.
No, ma'am, it should be
Ma'am, there is
TVS
one
only because it will
confusion there, ma'am.
reclassify 60% of the cases. It should be K
Yeah,
only.
whether it is at 20 weeks or 20 weeks TVS or it is TVS at 32 weeks. Because in guideline it is given us, it should be confirmed with at 32 weeks with ultra TVS.
No,
That line is given.
it's written that if an anomaly scan, if placenta previa is suspected, then we should confirm it by TVS because it can reclassify up to 44 to 60% of the cases. Ma'am has also told this in her slides.
Yes.
Yeah,
So
it's
just
there, but
understand
the guideline is given clearly that transvaginal ultrasound at 32 weeks.
Okay,
That's
just
for
listen to
confirmation.
me.
Like if in
Just
20 weeks we will confirm placenta previa, then again we will repeat at 32 weeks. That's a different thing.
okay, just listen to me. So if you are doing anomaly scan today, anomaly scan is usually done with the abdominal ultrasound. If you are doing abdominal ultrasound today and you have got any suspicion today only, then you can do transvaginal scan today, because there will be possibility in 26 to 60% of the cases your decision of placenta previa will change. Okay, this is the one scenario. But next scenario, if they said that it is the placenta previa and at 20 weeks scan, so what will be the next step? Okay, or when you will call this patient next for the ultrasound, then it will come TVS at 32 weeks. Is it clear now?
Okay, ma'am. Okay, ma'am. Here we'll go with MRI, ma'am.
Yes, because if you have got any
Ultrasound
suspicion,
leads to what?
yeah, if you have got suspicion with USG, you have to consider MRI. Someone was asking this question. Now she should understand from this question. So now the
Then
things will be
imaging at
clear with this
32
answer.
weeks. Imaging at
Okay.
32 weeks. Okay, ma'am.
Yeah, so now this was the confusion. In previous question, it was not confirmed. They have suspicion. So they are doing TVS on that day. But in this question, it is already confirmed. So you have to speak about 32-week scan.
E, ma'am. It is level 2 critical care bed, not level 1.
Yes, it is easy question. So these are the questions from Justin Conji book. So have you read question?
Yes, ma'am.
Options.
T, ma'am. Ultrasound scan including TVS at 32 week gestation.
Yes, but now everything is easy. Yes, you're right.
Ma'am, question, please.
It is V, madam.
Yes, it is. Okay, why I have put S? It is V. What is S? Actually, S and V. Okay, no, it should not be V, you know. Oh no, it is. Okay, it is the same. S and V are the same.
Both are same, ma'am.
Yes, S and V both are same.
Here it is TAS also, ma'am. In V, it is ultrasound including TAS, means both TAS and TVS in V.
It is not written that AS.
Okay.
We only TVS and TAs, ma'am.
Yes.
Yes,
So
is
answer.
only TVS.
So best answer will be
Please
S.
show the question again, ma'am. I missed that question, ma'am.
Okay. So it will be 36 weeks TVS. So S is
It
better
should be
choice.
S. Yes, ma'am.
Yeah, S is better
S will
choice.
be better. Better
Yeah.
choices.
So with these small mistake, you can do question wrong. S and V both are same. Okay, but S is much better because they are writing only TVS. So we need to learn from the mistakes. So now she has Vasa Previa. What you will do?
A, ma'am.
A,
Admit
madam. A. Admit, yeah.
30 to 32 weeks of gestation until delivery.
Yes. Single most appropriate. Better than that, what could be the thing?
Steroids.
B, madam. B, madam. Administered the steroids also.
Admit until delivery. Delivery, it could be vaginal also. You will do cesarean, elective cesarean only. So look for best management is steroid and elective.
It should be F. F.
Yes, it is F. Okay. So now these are the tricky things. Admission, if they ask you what is the next step, okay, then you can go bring this in the answer admission. But if they ask most appropriate in their management part, so management means no, it is admission, but it is steroid plus section. Okay, so you have to understand question. So it is CS and steroid.
The patient
Now
should be admitted.
yes, this patient should be, so she will be admitted delivery.
B.
And
Answer should be B.
yes, and steroid.
Please show the question again. I didn't read it,
Vasa
ma'am. Please.
Previa. Type 1 Vasa Previa.
Type 1 cesarean section.
Type 2, ma'am. Type 2 Vasa Previa. Suction rate lobe is there, ma'am. Membranes also there.
So it's about diagnosis. Okay, so it's J.
Yeah, it is type 2 Vasa Previa.
Low-lying placenta. No, normally sighted placenta, ma'am.
No.
It's 2.5 centimeter.
But it is an IVF pregnancy, so
That
But
also means
Normally situated placenta.
you have measured, it is not within 20 mm of internal loss, so it is normal.
yes, ma'am, it is normal.
So such a silly mistake can happen. We always think
Yeah,
of,
ma'am, actually, I was thinking it more into the line of Vasa Previa, as IVF pregnancy is a high risk for Vasa Previa. So more or less, I was thinking in that way actually.
No. IVF is one of the risk factor for Accurita, for Placenta Previa also, Accurita also, Vasa Previa also, for everything that is a risk factor. But again, if you see the diagnosis, if you see this, you will not do mistake. It is normally cited placenta. So this type of simple questions do come in the exam, and the problem is that we do simple question wrong.
Ma'am, in that recent talk of IVF pregnancy, IVF and complication in singleton pregnancy, there was one line written that whenever placenta previa is suspected in case of IVF pregnancy, so we should always done a TVS with color Doppler, as it is a high risk of Vasa previa. So whenever in option there is TVS with CD, so we should go for that, ma'am.
If they're saying about diagnosis, then you have to say TVS with CD. We did this line in the guideline. We did this. So according to guideline, it is combined TVS with CDI.
Yes, that is for Vasa previa particular when they are asking about Vasa previa. But when they are giving IVF pregnancy with suspected placenta previa, then also we should mark TVS with CD because it is given in talk, ma'am.
First of all, whatever the question, first try to give answer from guideline. If you never find that part in guideline, then you give from talk. Okay, whenever you have got any problem, like whenever you think of any kind of accreta or invasion or anything, you have to put color. Okay.
Okay, thank you, ma'am. It's previa F.
Placenta previa, ma'am.
It's F.
Yes, yeah, it's F. Okay, these are bad questions from strategy.
Induction of labor, ma'am.
Blood transfusion and observation.
Why you want to induce at 28 weeks,
Observation, ma'am.
Yeah, I'm sorry. I didn't see the weeks, ma'am.
So it is blood transfusion and observation.
But ma'am, loss is only 500 ml.
500 is quite a good amount. And what you will put, and you see the answer?
Options, yes, ma'am. There is no only observation, yes, ma'am.
Only observation is not there.
Yeah, that's why even I marked that.
Elective lower segment cesarean section, ma'am.
Yes, very good. Now grade 3 placenta previa, though IUD, you have to deliver it with anesthesia. But there is no emergency.
Elective cesarean section.
Yes, transverse lie. Yes, transverse lie, it has to be elective CS.
Ma'am, in the previous question, so it is not less than 28 weeks, so we go with lower segment section, no? It's not classical section. Correct, ma'am?
It should be induction of labor.
Yes, because it is grade 1, induction can be done. Okay.
It should be cesarean section. It should be cesarean section. Immediate elective lower segment cesarean section.
Grade 3 will be elective or immediate?
It should be immediate lower cesarean section, ma'am. Immediate lower segment cesarean section.
Yes. Because grade 3 placenta previa, if it started bleeding, It will not wait till
Yes, ma'am.
morning to do
I was
everything
looking
right.
for emergency actually. Here also immediate cesarean section.
Immediate
because-
lower segment cesarean section.
Because so much bleeding is there.
But here, yes, ma'am. But complete scenario is not given.
Complete scenario.
Ma'am,
Yeah,
suppose if the patient is in active labor, yeah, something like this, and
yeah.
These are
And
EMQs from strategy, I think.
these are strategy questions. Say, this much is given on.
yes, ma'am. It should be immediate cesarean section.
Transverse lie IUD, uterus tense, difficult to feel. It has to be cesarean. So it has to be immediate cesarean.
Immediate cesarean section.
Yes.
This option is not a resuscitate mother.
Yeah.
Otherwise, because she is hypotensive and tachycardia.
Yeah, so it is immediate. Answer should be resuscitation in immediate section, but as resuscitation is not there, so we will put this in the answer.
Section, immediate section, ma'am.
Here also immediate cesarean section.
Yes, because maternal compromise is there. Okay, she blood pressure is falling and she is having tachycardia, so you have to take
Ma'am,
this
can't
baby.
we do an ARM, ma'am? Because what we do in clinical practice is whenever we suspect abruption, then first of all we do a PV and ARM, like what is the cervical finding if she is in advanced labor.
But they have not given PV finding, and they have not told you how much dilatation
Ma'am,
is there.
Seeing the explanation, the woman delivers in theatre preoperatively or on the way to the theatre. The quickest method of delivery has been taken. So we go with the cesarean section, ma'am.
So here it is, she is 32 weeks with bleeding, uterus is tense, tender. Okay, what is the best management? Why? Because they have not given finding, and mother is going. Maternal compromise is there, PV findings are not there. So
अक्षय ये क्या करते हो तुम फिर गुस्सा आता है मेरे को
Agreed, ma'am.
yes, it is pethidine, because now IUD is there, labor is already progressing. You have to just calm this mother. Please give pethidine.
Here we'll go with the ARM, ma'am, with the Synto infusion.
Yes. ARM with centosin or infusion.
Immediate cesarean section, ma'am.
Yes, immediate cesarean section. Now fetal heart is falling.
ma'am, why was ARM in that question answer?
Here also immediate cesarean section, ma'am, because the fetal heart may drop at any
Yes,
time.
in
So
this-
we need to take the baby out immediately.
In this question, why the answer is ARM, ma'am? Previous IUD we were doing cesarean section directly.
No, for IUD we were
I think
not
it
doing.
is placenta previa. Here it is abruption.
This is the finding of abruption.
Yeah, this is the finding of abruption, but the mother is unstable, and they have not given us the PV finding. If the bishop profile is poor,
Yes, in that
and the
situation
maternal.
you have to do cesarean section. Maybe USG confirms death. Why you want to do section for IUD?
Ma'am, in case of IUD, if the maternal bishops are poor, like one finger or two finger, even if we did ARM and the frank blood is coming, and we are going to induce the mother, it will take time, and the mother is already going in shock. So we will do a cesarean for my maternal indication.
No, that is fine. In that, if they want cesarean in the as an answer in this situation, they will give more bad blood pressure and more high pulse. Okay.
Okay,
So
ma'am.
I mean, abruption, we need to assess. We need not to do immediate cesarean section for IUD.
Yes,
If the baby
that's
heart
true.
rate is fetal heart is there, we need to do to save the baby.
Because
yeah,
there is almost 36 centimeter that SFH at
yes,
32B. So it should be massive abruption.
it can be there, but again it is IUD. You will not do unnecessary section. You will, in this situation, your baby is already gone, so there is a place for ARM. You will do ARM. All collected blood may come down. She may get relief from some abruption, and then you can start with oxytocin. IUD immediate
Okay.
section will not come in the answer.
Actually, ma'am, I'm satisfied with the answer, but I'm just thinking ki exam mein when we'll get this scenario, so I might not get confused. That's why I'm asking this question, ma'am.
Yeah, the APH question, this type of question comes in APH. Like this whole question, it is the same EMQ. It is in the various parts. So I'm showing you question is same. And options are also same. Answer changes. This question come in the exam.
Yes, ma'am. True, ma'am.
Here baby is live. Okay.
Immediate cesarean section, ma'am. Immediate cesarean section.
Yes, here it will be immediate section. Because baby is live. And CTG is fine. Now here there is a problem because fetal heart dropped
Here
down.
also immediate
So what
cesarean,
you will
ma'am.
do?
Immediate
Because you are
cesarean.
dealing with Vasa. Yeah, because
Ma'am,
it is Vasa
can't
Previa.
we do, ma'am, can't we do category 2 cesarean in the previous question in which the CTG was normal?
Yes, we can.
But
We will do category, but they have not
maternal
given that in
compromise is
that
there,
option.
ma'am. Maternal compromise.
Okay, ma'am.
So
So it should be
you will,
category 1 only in this.
if CTG is fine, mother is almost stable, not very bad condition. She can go for category 2. This will be category 1.
1.
Okay, this will be, yeah.
It should be category 1 cesarean section. B. It is a rupture.
Yes,
Rupture uterus.
it
Yes.
is a rupture. This type of question they do come in the exam.
It should be B. No, C. Steroids also, ma'am. C.
Crossmatch and
Yes,
steroids, ma'am. See.
yes. Whenever you see preterm, please give steroid in the picture. See, easy question.
Platelets and FFP.
Yes, this is the
300.
answer. Yeah.
patients should
offer corticosteroids, ma'am.
Yes, because you can give it from 34 plus 6 days. So they want corticosteroid in the answer. Okay, so thanks.
thank you
Anyone?
ma'am, thank you.